IgA nephropathy, also known as Berger's disease, is the most common form of glomerular disease in the world and can eventually progress to kidney failure. Although it is likely that there are some contributing genetic factors, the cause of IgA nephropathy remains unknown. Interestingly, the onset of the condition may be associated with mucosal lining infection, such as that of the upper respiratory tract. So, what actually is IgA nephropathy? Well, IgA is a type of antibody that serves to neutralize pathogens. Humans produce two subclasses of IgA, IgA1 and IgA2. It is IgA1 that seems to be responsible for the development of IgA nephropathy. Normally, many sugar molecules called galactose attach to the IgA1 antibody. When too much of this molecule accumulates in the body, it is degraded. However, in IgA nephropathy, an abnormal IgA1 is oversynthesized, one that has less galactose sugars attached and hence cannot be identified and removed by the body. A subsequent immune response prompts the release of IgG antibodies to neutralize the abnormal IgA molecules. As such, abnormal IgA1 are found nearly exclusively attached to IgG antibodies and form what is known as an immune complex. The circulation of these immune complexes prompts concern as they approach the kidney. Within the kidney, small functional units called nephrons work to filter blood and remove waste products. The initial portion of this structure is called the glomerulus, which consists of the mesangium, a cluster of cells that support the capillaries and efficient filtration in the kidney. The immune complexes are prone to deposition within this mesangium. Once deposited, the body's immune response will contribute to local inflammation, the scarring and thus hardening of these capillaries, and ultimately glomerular injury. IgA nephropathy may present no symptoms for a number of years. Once symptoms appear, the most common one is hematuria, which is identified by the presence of blood in urine. Hematuria can be macroscopic, that is, seen by the naked eye, or microscopic, and can only be detected via medical testing. Other symptoms include proteinuria, or more simply, the presence of protein in urine, which is typically characterized by a foamy appearance, edema, or more simply, swelling, typically in the lower legs, and high blood pressure, also known as hypertension. The scarring of the kidney is permanent, and therefore there remains no cure for IgA nephropathy. However, there are treatment options that target the immune and inflammatory events to slow disease progression. Such interventions include the use of ACE inhibitors and corticosteroids such as prednisone. Although these treatments have not been observed to preserve renal function per se, they can reduce proteinuria and lower blood pressure and inflammation, both of which are significant risk factors for progressive disease. Renal transplantation is typically recommended for younger, otherwise healthy adults in which end-stage renal disease has developed. The management of IgA nephropathy focuses on the rigorous control of blood pressure. This can be achieved by reducing salt and cholesterol intake and adhering to hypertensive medications. For more information on IgA nephropathy, check out the following links.